Welcome to the OC24 podcast, where we've taken some of the best talks and discussions from this year's 24-hour conference on global organised crime, which showcases some of the most interesting research into organised crime around the world. This episode is called Breaking Drug Policy Silos in Francophone Countries, Breaks and Opportunities.
Welcome to this session of the 24 Hours Conference on Global Organized Crime. My name is Laurie Doviak, and I will be the moderator for today's panel. This session is entitled Breaking Drug Policy Silos in Francophone Countries, and the speakers will present insights on the current transformation of drug policy from two different countries, France and Canada, where, of course, the context of drug policy are very different. Each presentation will be 10 minutes, and they will be followed by a very brief questions and answers session of around 5 minutes for specific questions. And then we will have a broader transversal discussion between all the speakers. I'll be monitoring questions in the chat, so please do ask them. Please be aware that the panel will be terminated in 75 minutes, so we will need to conclude on time. And we will start now with the presentation by Marie-Geoffrey Roustid with an international perspective on the effects of COVID-19 on illicit drug and drug policy. Marie-Geoffrey Roustid is a research fellow at INSERM, so the French National Health Institute. She's also a senior fellow at the Baldy Center for Law and Social Policy at the University of Buffalo in the US, and an affiliate scientist at the British Columbia Center on Substance Use in Vancouver, Canada. She's worked for 30 years on the politics of harm reduction in France, Europe, and North America. So please, Marie, you have the floor for 10 minutes.
So thank you, Laurie. Can you hear me?
Yeah.
Okay. So thank you, Laurie, for introducing me and for sharing this session. So today I will present some very preliminary results from a survey that I did with my colleague Karine Bertrand from Quebec. So this survey is focused on the impact of COVID-19 on harm reduction and drug treatment services. And I will present the result from two qualitative surveys that have been conducted in France and in Quebec. But as we have only 10 minutes, I will be focused on the French part of the survey. And in the discussion, it will be possible also to have a more broader overview and to talk also about Quebec. So to begin, it's important to say that COVID-19 is not only a pandemic, but it can be considered as a syndemic, as it has been described by Orton in The Lancet in 2020. What means saying that COVID-19 is a syndemic? It means that COVID-19 increases or reveals social and health inequalities that are affecting the most vulnerable people. In a syndemic situation, several disorders can aggravate each other, and especially they are accentuated by social conditions such as poverty, stigma, stress, and structural violence. And people who use drugs are especially to face deprived social conditions such as poverty, stigma, stress, and structural violence. It's also important to note that addiction disorders are often associated with health comorbidities, and that's why in the context of the COVID-19 pandemic, people who use drugs are at higher risk of infections, and they can be more affected by serious consequences of COVID-19. As a consequence of this, of considering COVID-19 as a syndemic, it's very crucial to implement measures that address health, but also social inequalities for vulnerable populations. During COVID-19, our survey has shown that services regarding harm reduction or drug treatment have been sometimes disrupted in France and in Quebec, but social innovation have also emerged in both countries. And that's what I will present now with a focus on France. So this survey is based on a qualitative methodology. So we did semi-directive interviews with people who use drugs, who attend harm reduction services or drug treatment services. And we also made semi-directive interviews with different stakeholders, including politicians and also harm reduction professionals and drug treatment providers. So one of the first results of this qualitative survey is that during the first phase of COVID-19, this phase was characterized by a very strong commitment of harm reduction and addiction treatment professionals in France. And all these professionals try to respond to this health emergency very efficiently, especially during the first lockdown. And it's also important to note that during the first lockdown in France, there was a huge lack of availability of masks during the first weeks of the pandemic. And despite this, professionals accepted to take risks to take care of people who use drugs in harm reduction facilities and drug treatment centers. It's also important, our survey also reveals that COVID-19 was an opportunity to create new forms of solidarity and new forms of mutual help networks between colleagues, between professionals who work in harm reduction and drug treatment areas. In France, people who use drugs have to face very few service closures, and there was a very good continuity in accessing to services. During the second phase of COVID, after the first lockdown, we can also note that more and more professionals who operate in harm reduction and drug treatment services were exhausted because they have been very, very committed during the first phase of the COVID-19. And services have to face difficulties because professionals have to manage family constraints, restrictions related to the pandemic, and a continuity at work. Regarding innovations in France, COVID-19 introduces an opportunity for having more flexibility in the duration of opioid substitutive treatment prescriptions. And it was also an opportunity for allowing new users to have access to opioid substitutive treatment, especially the most marginalized users. So a lot of drug treatment centers accepted to have new patients. And this improvement in access to medicines was a way to limit overdoses linked to a potential increase of people who will probably buy heroin on the black market with no guarantee about the dosage of the heroin, the purity of the heroin that they will buy on the drug market. So we can say that COVID-19 has revealed one of the strengths of the French harm reduction model, because the French harm reduction model is based on biomedical model of a very broad access to opioid substitutive treatment and an easy access to this treatment into community medicine. Another important result from this COVID-19 survey was that in France, public authorities decided not to increase the repressive approach to black markets. They decided at the opposite to improve access to medicines. And at the opposite in other countries that have different policies, such as the US, and less sustainability of harm reduction services, the increase of overdoses was very, very important at the same time. So another result of our survey was that COVID-19 was also an opportunity for improving the access to housing for marginalized users. For example, in Paris, several hundreds of rooms were implemented for the most precarious users who were living in the streets. And we did some directive interviews with users who can benefit from these new rooms during the COVID-19. And they talked a lot about the very positive effect of housing on their life trajectories, and especially on how it allows themselves to self-regulate in an easier way their use of drugs. And this access to housing during the COVID-19 period was also an opportunity for them to have access to treatment and to social rehabilitation. So it was a real improvement of their life, of their daily life. So this innovation have been implemented also to reduce pre-existing weaknesses of the French care model, because the French care model is largely focused on the biomedical dimension and was not very much focused on social rehabilitation for people who use drugs. And with this COVID-19 pandemic, we reveals the importance to also act on social aspect of drug use. COVID-19 was an opportunity to improve this aspect of harm reduction in France. So COVID-19 was a way to overcome an approach to drug use and addiction in silos and to reconcile medical aspect and social aspect of improving lives of people who use drugs. Something that is also very important to say now is that this improvement in accessing to housing for marginalized users need also to be sustainable during time. And another important result from our qualitative survey was that we can also observe from the semi-directive interviews with users that they have to face a more tolerant attitude of a part of police officers toward marginalized users who live in the street during the first lockdown. At the opposite, people who were living in the street have to face a lot of discrimination, especially from some residents who put very bad pictures from people who use drugs on social networks, and some residents had a lot of negative words about people who were living in the street. And when we compare the attitude of police officers compared to the attitude of some residents, the attitude of police officers during the first lockdown was a better one and a more tolerant, especially towards the most marginalized users. And that's why COVID-19 has also made possible to rethink care in a global and complex manner. This was an opportunity to promote a more inclusive and integrated strategies that go beyond strictly repressive strategy, because it's important also to highlight that France is one of the most repressive countries towards drug use in Europe. And that was important to see that during the COVID-19 pandemic, there was a balance and between social care and repressive approach, and stakeholders who were more repressive towards drug users before the COVID pandemic as another attitude, more tolerant during the COVID-19 pandemic.
Sorry, Marie, you'll need to wrap up within 2 minutes.
Okay, so I have 2 slides now. So additionally, before COVID-19 in France, there was a very punitive approach of alcohol use for marginalized people who were living in shelters. And during the lockdown, this punitive approach was not possible anymore. People who use drugs ask for having the possibility to drink alcohol occasionally, and professionals need to revise their practices and need to be more open-minded to harm reduction with alcohol use. So we can say that COVID-19 has shifted the values and practices of professionals to give up their punitive approach of alcohol for people who use drugs, and to consider the well-being of people who use drugs more important than a repressive approach for alcohol use. To conclude, we can say that COVID-19 reveals the strengths and the weaknesses of the French addiction treatment model. France is characterized by public funding of the services, which has facilitated continuity of services for harm reduction and drug treatment. France is also characterized by a sustainable and highly structured care and harm reduction system based on large NGOs that are only focused on people who use drugs. And this point is a bit different compared to what happened in Quebec, for example. And the health system in France is also very structured and has resisted quite well to the COVID-19 until now, with little transfer between services in the field of addiction to COVID-19 services, for example. Nevertheless, our survey highlights that some territorial inequalities have been noted in France regarding the improvement of access to care and housing during COVID-19 for people who use drugs. And another very important result of our survey is that in France, we have strong intermediary institutions that are national networks of NGOs. And these national networks of NGOs were able to influence the French public authorities to change rapidly policies because of pre-existing alliance. And this pre-existing alliance between this national network and NGOs and public authorities made possible the addiction treatment system and harm reduction system to evolve rapidly and to be more adapted to the needs of people who use drugs.
Well, thank you, Marie, for a very interesting insight on the effects of COVID-19 on drug policy and illicit drugs. I don't see any questions in the chat, so we will go on with Karine Bertrand's presentation. She will tell us more about the tapage program currently implemented in France and Quebec. Karine Bertrand is a clinical psychologist. She's a professor in community health sciences at the University of Sherbrooke in Canada since 2006. She's also a scientific director at the Addiction Research Institute in Quebec and a chairholder for the research chair on gender and intervention in addiction. So please, Karine, you have the floor for 10 minutes.
Thank you for this invitation. So the topic of my presentation is about the harm reduction program based on low threshold work for youth living in situations of social precarity. And we will also discuss the implication of for social and health policy. So young people living in situation of social precarity have numerous associated social and psychosocial problems. So delinquency, but also addiction, residential instability, addiction, and barriers to employment. Before going further, what is social precarity? What do we think when we talk about this concept? So maybe at first, it's important to see the intervention, harm reduction intervention with the lens that is global. So we want to take into account the individual, but also its social context. So we can relate the concept of social precarity with the risk environment of roads. The main principle is that if you foster economic security, it's a way to reduce risk associated with drug use. So when we try to understand delinquency, we will conceptualize delinquency like one of the many complex health and social needs that a person have because she's confronting multiple dimensions of social precarity. We talk about social and emotional support, for example, economic precarity, the employment, barriers to employment, and also housing, for example. So the context of this study is also situated at first in Montreal, where it's been a long time that we just document that there's a vast majority of the street youth in Montreal who have a substance use disorder, and as well often associated with mental disorders. So we had some data from 2010 with the cohort of Elise Roy. But now what is new is that the community organization try also to look at the needs for the economic security and the employment aspect. So when we look at the literature to understand well the link with substance use and work, we see that there is a really complex interrelation. For example, unemployment can predict psychological distress and also the aggravation of substance use. And the other way, we also see in longitudinal studies that the aggravation of substance use predict employment problems and unemployment. And another type of literature is, and it's more recent, we have looked at the access to paid work for active drug user. Often we see the paid work as that is indicators of outcome of success after a treatment when the drug user is not using anymore any substance. And we realized with this work that, in fact, active drug user, even street youth, have some access to paid work. And when they do, it's associated with reduction of HIV risk behaviors, better mental health and physical health, reduction of criminality, and also engagement in care. So based on these data, some authors just highlight the relevance of low threshold work for harm reduction programs. This type of program is based on a holistic conception of harm reduction, with the potential to address some of the complex needs of street-involved youth, including those related to substance use and its consequences. So this type of programs also opening the way it's opening the way for a longer term process of social occupational integration. But at the beginning, it's not necessarily to help the person to have a normal, if we can say, job, but use the work to help the global health of this person. So based on this principle, we have some data that validate the relevance of this type of programs, but we need more adequate evaluation of such approaches. We see some of these programs in cities like we will see in Montreal and Bordeaux in France, but it was not evaluated in the world more globally. It's rarely evaluated. So to guide program and policy development with respect to harm reduction programs that incorporate access to low threshold work, one of the aims of this study is to understand the perspective of the young people who participate in this low threshold work program called TAPAGE, in terms of program goals and the relevance of this type of program, and also the meaning it has in their life. So it's a study who put the focus on the experiential knowledge because we think it's the added value that is important. This participatory research gives really priority to the voices of these young people because we think they have some useful knowledge to influence our effort to improve this type of program and also to develop more holistic harm reduction practices. So rapidly for the method, we did a qualitative evaluation design study with an approach that is participatory. We want to improve program and practices to bring solutions to identified problems. So we work with stakeholders at every step of the research. And we also put some importance about research and evidence-based practice, but also the experiential knowledge of the clinician and of the youth who use the programs. And it's oriented with a capacity building approach. So, well, maybe just fast also, we have a research committee with peer researcher and clinician involvement. And we also have a research panel, low threshold research panel with 20 young people since 2018 that participated, including 8 to 10 youth that is participating on a regular basis. We did focus group, 14 focus group, and interviews in Montreal and in Bordeaux about the participation, about the program, and with the youth and also the staff, partner, and employers. It's important to say that at the beginning, it's for 20 is in Montreal, and after it was in Bordeaux, and for now it's everywhere in France and many regions in France. It's really there's more tapage in France now than in Quebec, but at the beginning it was in Montreal 20 years ago. Okay, so some essential results. So the essential components of tapage from the program participants' point of view, and it's the same for other stakeholders. Essential components are the on-the-job accompaniment and support from program staff, measures that reduce barriers to employment also, so a fast, simplified procedure, tolerance of substance use, being paid on the same day, and also the access to a quick source of income that is central and it's an immediate concern. So this is an important part, not only to get the youth in the program, but also per se, it's important to respond to an immediate concern. So we see, for example, that this kind of money can be important to pay debts and also to have food. Another essential component is that TAPAGE puts conditions in place that allow young people to experience success in their efforts to earn a legal income, in contrast to previous attempts at work that are often marked by numerous failures. So sometimes for many youth, it's the first time that they can earn a legal income and feel really proud of themselves and not in a failure dynamic. Another type of component is the importance of the relational dimension of the program, and this is with peers. For example, you have a young person, who said, when I was working with my peer, I thought it was really going to explode, but no, we managed to do what we're supposed to do. So the group aspect, so to work together with other peers and to have a relational harmony in this situation of work is really something that comes in what they say like really important in their experience, and also the relational dimension, of course, with the clinical staff that are supportive, non-judgmental, and also have a comprehensive approach. Another aspect is the reduction in stigma. The program participants highlight the harm caused by stigma in their life, and also the perception that TAPAGE leads to change in how society perceives them. So you can see, for example, that for some of the participants, they say if you have mental health, you're a bipolar woman, schizophrenic, and all that. It's that they accept you anyway because they are at workplace that will refuse to have you. So being different in many ways, not only because you have precarity, you use drugs, but often for other many reasons, they feel that they are rejected by the society in general, but also specifically by workplaces. So this is another aspect, to have a different experience and being accepted. That was really important for them. Also, reduction of stigma, because TAPAGE make them proud of their work, and even for one participant to exercise citizenship. So you have, for example, a transcription where the young person explain that they have a success when they see, for example, that we would need to have some benches in the place where it's not well. I mean, it's not. For example, for citizens, you need, for example, garbage cans, and you need benches, and so they go to the city and they ask for these things, and they have a success in their different arguments and requests. So he was really proud of making a difference in his city.
Sorry, Karen, you'll need to wrap up within 2 minutes.
Perfect, thank you. So I was at the end. Another ultimate goal is to also have the personal autonomy to the achievement of life goals. So when we pass the immediate concerns from, for example, food and economic needs, they talk also about the importance of this time of harm reduction programs to achieve their life goals. So it's an adequate answer, this type of programs, to immediate needs, but also to answer to multiple needs, multiple dimensions of autonomy. So in conclusion, I would say that integrated addiction and community services must be developed in order to address complex social and healthcare needs. That low-threshold paid work is one example of a capacity-based intervention that uses an innovative and integrated approach to harm reduction to go beyond traditional biomedical and risk-based approach. That low-threshold paid work may contribute to the prevention and reduction of delinquency, and that taking into account the perspective of young people who participate in that type of program, draws attention to the need for harm reduction programs to address factors in the social environment that contribute to the stigmatization of vulnerable street-involved youth and their retention in a marginalized lifestyle, in order also to better prevent associated risk behavior. Thank you for your attention.
Well, thank you, Karine. I don't see any questions in the chat. Feel free to ask them. We will then continue with a presentation by Deborah Alemi, will let us know about the state of drug policy in France. Deborah Alemi is a researcher at the European Center for Sociology and Political Science at the Panthéon-Sorbonne University in France. She has an expertise in drug policy and sustainable development cooperation. She contributes to the newly launched Aleph research platform. She is also an independent consultant, especially at the UNODC. So please, Deborah, the floor is yours for 10 minutes.
Thank you very much. Well, thank you, everyone, for this invitation to this panel. I'm really thrilled to be here, and thank you, Marie and Karine, for your very insightful presentations. Mine won't be as rich in terms of fact and results from survey. It's more, I would like to share today more of some reflections on the state of the drug policy debate in France and more generally. Actually, I'm going to start with a broader picture of the drug policy debate to come back to the French case with one question that one question that really concerned me for some time now is why the drug issue and drug-related problems are not considered as a development issue in the sense of a social economic issue. For a century now, more or less, the drug issue has been framed mainly as a security issue and a health issue, but nothing in between. We have developed binary vision of the problem at stakes. There's a lot of different factors that explain this. There's a lot of literature on that, and I'm not going to go through them because it's going to be too long. But there is this sense that the drug issue could only be treated one way or the other. Now, we also see in different societies that drug realities are a transversal phenomenon. They imply different kind of population, different kind of countries, I mean, different kind of socioeconomic development, etc. And it's there in the social construct, in the institutional structures as well, in the political fabrics as well, considering that the drug transaction or a transaction involving the drug trade can be present here and there. Now, I would like to make now saying this introduction, I would like to make 3 points to reflect on the perspective and good practices that have been provided today, and to open up a bit the discussion on why and how the drug issue could be more read as a social issue and a development issue. I'm using both terms because I know that the development term is still can be problematic for some people. It's not, we don't have, everyone don't have the same definition of sustainable development. I'm using the UN definition of sustainable development and the multidimensional facets of that concept. But it's really on the social dimension today I would like to focus. So there's been increased evidence that the drug-related problem from the demand side or the supply side, replicating the policy category that we have today, have a social dimension and need multifaceted and tailored political treatment. We've seen in the presentation that Marie proposed, the COVID epidemic really invite stakeholders at the field level, at the practitioner level, and at the political level to readjust their grid of interpretation of the drug issue and how services could be delivered to people using drugs. There's also good practices developed, and the tapage example is a very good one that imply more involvement of other actors of the political spectrum and different sectors of intervention, the health sector, the housing sectors, and other examples imply the education sector, urbanism, etc. And at the international level, more broadly, in the past 5 years now, or at least, decade, more or less, we've seen an increased momentum to reread the drug problems through a development-oriented lenses, meaning that there is a change of vision that started in 2012 with the Latin American call to open up a debate on drug policy and to revise, or at least to reflect on what have been done so far, and why the repressive approach was not a unique recipe that could be applied anytime and anywhere. And this launched a global debate that ended in a UN event called the UN Special Assembly on the drug problem, that came up with a new it's not so new now because it's 2016, but it's new in the way the drug problem has been framed. So in this document, there is a real engagement to break the traditional pillars of drug policy that goes on drug supply, drug demand, and money laundering, and to extend as well the policy offer, if I can say. There's 7 chapters that articulate different dimensions of the drug problem. So really a reappreciation of how drugs are involved in a society, in a community, at the individual level as well. We've seen, in my second one, despite the increased evidence and increased political momentum around the need for I had a French term, I'm sorry, around the need to break the silos actually of drug policy, orchestration of new pilot program on demand, but also on the supply side. And I'm thinking of Colombia, of different program of alternative development that reread the development component of these measures to reintegrate the families and farmers who are cultivating crops used for producing drugs into alternative path of socioeconomic integration. It hasn't been working so well because of political turnover and so on, and mainly, but this is an example. Another way of reflecting on the issue is to also read the drug issue as a human rights issue. And we have a community of researchers, of policy practitioners, of NGO who have been issuing guidelines on how merging those agenda. And actually there's a guideline called the Guideline on Human Rights and Drug Policy that give some inputs on how bridges could be built around these different issues. And even at the UN level, there were some starts of greater policy coherence translated in a position paper of all UN agencies calling for greater coherence on drug policy and development and human rights. So there is some signs that that the way forward would be really to break this policy and these interpretative silos. Now, what I've been looking at as part of my research on policy making processes at the international level and at national levels, well, I've mentioned that, but you understood that I'm looking at policy processes and the construction of international policy making. So what I've seen is all these initiatives are isolated, and there is no real political engagement beyond a community of practitioners, beyond a coalition at the UN level pushing for greater language on this approach, beyond pilot approaches in different countries at national level. And multiple factors can explain, again, the lack of political will and this isolation of the different initiatives. One of, three factors that we could look at was the concept. As I said in introduction, the development can mean anything for anyone. And aligning on the UN definition is even not really helpful for national or local actors that are quite far away from this whole conceptual discussion that take place in other forums, and are sometimes also far from the realities from the ground. The second factor is a political one. The international consensus on drug policy, some would say is fragmented, others, as me and other researchers would say, is still searching itself and is in tension because of all this new alternative way of reading the drug issue. And one of the clear manifestation of this tension was the 2019 ministerial engagement of the Commission on Narcotic Drugs, the main policy body of the UN, who recognized the complementarity between drugs and development, the need to overcome the compartmentalized way of reading the drug issue, but still also recognize the complementarity of different engagement on security, on health. So mainly pick and choose kind of a way forward. And the third factor is research and dialogue one. There is little, despite existing evidence, there is little diffusion of this evidence and limited conveying of this evidence toward policymakers. And that's where I come to the French example. As Marie presented, the French vision of the drug problem is mainly a biomedical one, and at least for drug use and how it is treated at the local level, at the field level, but in the law and in the norms, it's mainly a security issue, framed as in any other country, in many other countries in the world as a evil or really a security problems. So what we decided to do was really to try to understand why so, and why all these research have not been conveyed to the political level. So we organized with Marie actually and Médecins du Monde and the Drug and Development Hub a series of dialogue and seminars online during the COVID pandemic to try to take advantage of this pause to reflect on how we could improve our work as researchers, as civil society practitioners, as policymakers. From that experience, first, we didn't reach out as many policymakers as intended, again, for political reason, I assume, but we actually could put on the table a vast panorama of research showing that there are some initiative, project, program that are defending and actually implementing a development-oriented approach to drug-related problems, but that have not been recognized as such. And that has been linked mainly, from my understanding, but that's maybe something that we need to discuss, but from my understanding, this shared vision is still not actually a shared vision and a common position, because of the still very political entrenched dialogue on drug policy, whether it is a scientific dialogue, a policymaker dialogue, or a practitioner dialogue. There is this tendency to always defend a position, and as I am actually doing so as well today, but there is this need to neutralize the policy debate and the scientific debate on drug policy. So that's where I would like to throw out some question here to reflect on how we could break the silos and not replicate the same categorization as the policy one in the practitioner debate and in the scientific debate. And I would like to ask you and us how to overcome the binary thinking grid on drug policy, and what kind of actor would need to be involved, what kind of evidence and research would need to be also engaged in the future, and there is any other experience from other organized crime field that could teach us some lesson to change this perception. And I would leave it there, and I'm sorry I talked too much, but thank you for your attention.
Well, thank you very much, Deborah, for a very insightful presentation. I don't see any question in the chat, so maybe we can start with Deborah's question, which are very interesting. I would be very interested in knowing what Marie and Karine think about them. So please, Marie, go ahead.
So thank you, Karine and Deborah, for your insight presentation. Deborah, perhaps to answer to your question, I think that one way to improve the level of the debate and to break the silos will be to have research, to do research with participatory methods. I speak from a perspective of a researcher because I'm a researcher, so that's not possible for me to speak from another perspective. But it seems to me that now the problem that we have to face in drug policy is that following your speech, we have a lot of stakeholders who don't take, who have very different positions that are different from each other, and that people who share the same view as always between them, and they organized conference and seminars where everybody agree, everybody has the same position, and that's very difficult to have conferences where people from different perspectives are able to speak together. So for me, as a researcher, what I can do for breaking this silo is first to do participatory research. Participatory research, that's what we try to do with Karine, for example, in several projects that we co-lead together, is to have on the table different people, such as practitioners in harm reduction or drug treatment services, and also people who use drugs. And when you involve practitioners and people who use drugs as being active actors of the research, that means that the differences that are usually between patients, between people who use drugs, for example, and practitioners are not the same, because when you have them on the table in a research, they are on the same level. The people who use drugs are not considered as a patient, and with a power relationship with a practitioner, for example, they are on the same table, and each opinion is important to hear. And I think that as a researcher, first I can do that to do to to promote participatory research, to allow different stakeholders to be part of the research. And the second thing that I think that is important also to do is to be able to organize conferences with stakeholders who don't share the same opinions. And that's why we try to do together, Deborah, with Marie Debru from Médecins du Monde. And I think that we achieve it in some way, because we succeed to have this roundtable with politicians, but politicians that are local politicians for some cities, where these local politicians try to do some innovation. And I think that it's also very important for researchers to begin a dialogue with politicians. And it seems to me that it will begin from the local and not from the national, because at local level, the innovations are more easy to implement. So that's the second point. And the third point that I think that we forget a lot in our debate is to involve police officers in the discussions, because researchers, as I am, and I think that's the same for Karine and for you, are convinced that the repressive approach doesn't work, because there is an extensive literature showing that repressive approach and prohibition doesn't work. And that's probably why it's more difficult in research and in conferences to welcome people who symbolized this repression, such as, for example, police officers. And I think that it's a pity, because when as an ethnographer, when I do semi-directive interviews with people who use drugs or with police officers, when I conduct semi-directive interviews with them, I can understand how the relationships between people who use drug practitioners or police officers are more complex than the policy that is repressive at the national level. So that's why I think it's very important to have also around our table of discussion also police officers.
Maybe I can comment on that. Yeah. So thank you. Like I agree with Marie. With the participatory research is really important, because I think that in this type of research, the social inequalities also surrounding drugs is really at the center of the preoccupation for person with lived experience, and also the other stakeholders, community organization. And it's often an aspect that is not taken into account in our different approaches. One thing that I want to highlight also is that often we oppose, like you say in your interesting communication, Deborah, the health and the justice approach. It's like in opposition, but behind that, it's often we see the person who used drugs with a moral lens. So we can see that it's a delinquent, or you have health problems, or you have a bad habit. For example, we see as weak, sick, with bad habits. So even with the health approach is better than say that it's a bad person because you have a health problem. So it's a step, but we still have this moralization lens and all the stigmatization of the person who used drugs is really important also in our politics and the offer of services that we give. So I think that when we try to do differently and to take into account the social issues and the social inequalities, it's difficult to structure and to implement this type of approach because of the silos that you're talking about. So how do we break silos? For example, in France, they was able to have Tapage France because they succeed in including the low threshold work in the Macron poverty. I'm sorry if I don't name it label okay, but it's the poverty plan. So when you put this type of initiative with the poverty plan, it was really a good aspect because we have a national conception that we want to help the youth in social precarity. But the drugs, it's there, but it was not that much related to harm reduction, but it's a beginning. So we acknowledge that it's also an harm reduction program, but and it contributes to the diminution of poverty. So it was a nice steps, I think, from the politic. It's a way that some silos were breaking in this initiative. In Quebec, they try. So, for example, the low threshold program is that in the new plan at the political level, it's an interministerial plan for person with for homelessness. So it's in this interministerial plan that we talk about this type of initiative in relation to drug use. So I think another aspect that is important is to work with government to think their action plan in a way that they themselves, they break the silos and talk to, for example, we have separate plan for addiction, for homelessness, for social insertion. And often we don't have a global perspective on this type of issues. So I think when we talk about this type of program, what is interesting is that we begin to make changes in the way they think their action plan at the government level. So that's so we hope in Quebec that with this type of plan, interministerial plan, that we will go further in the applicability of this type of programs all over the province, because for now it's not we have an application of this type of program, because who will give money? Is it the responsibility from the education stakeholder, harm reduction stakeholder, etc.? So these silos put very high challenge to implement this type of harm reduction holistic approaches.
Thank you both for a very interesting answer. I guess I would bounce back off on Marie's answer. You talked a lot about dialogue, and I was wondering how this frame of dialogue could be implemented in different contexts in Francophone countries, and more especially in Canada and in France. Are there differences between both contexts in the way dialogue can be implemented?
I will briefly begin with France and perhaps also give the floor to Deborah, because she's also she's also French, so she also can speak about the French case. Regarding France, what is very complex, I don't know if it's the same for Quebec, is the fact that we have a huge gap between the Ministry of Health and the Ministry of Interior. So and it's especially visible now with our Minister of the Interior, Gérald Darmanin, because at the Ministry of Interior we have this repressive lens that is so huge in France, and we have this prohibitive lens that is totally opposed at the health perspective. And for example, now we have to face in France a lot of difficulties for implementing drug consumption rooms due to this opposition between the Ministry of Health and the Ministry of Interior. So in France, it seems to me that one of the main fears of the politicians regarding drug policy is to be considered as a proselyte. So all French politicians hesitate to speak, for example, about legalization, cannabis legalization until now. So that's quite news that some voices for this presidential election accepted to put this topic on the table, but until very recently, only the Green accepted to talk about cannabis legalization. And because of this repressive lens and these fears of being considered as a proselyte. And for example, in Germany, that is a country that is near France. There is a coalition of politicians who are favorable of cannabis legalization and who are very comfortable with speaking very openly to this topic without having the fear to be seen as a proselyte. And for drug consumption room, for example, the situation is totally blocked in France because it's a measure that is accepted from the Ministry of Health and that is allowed by the Public Health Code. But this prohibitionist vision lens of drug policy in France impedes the implementation of this health measure and probably due to this fear of proselytism. And each time we talk about drugs in France, there is always this confusion between harm reduction measures, for example, and the dangers of the drugs for young people. So the discourse is always emotional, and that's very difficult to have drug policy in France that are evidence-based. And with the COVID-19, what I try to show is that as we were in an emergency situation during the lockdown, that was a unique opportunity to change policies, but policies have changed only at the local level. And at the national level, this opposition is still very strong due to this fear of proselytism. So Deborah, probably you will have other things to do on this topic.
Thank you. I will actually add up on what you say and maybe come back a little bit on the concept of control and repression. First, I agree with everything that has been said, and I would add the individual variable in here because people matters actually in politics. We don't have only institutions or states, but people matters, and the personal vision, the moralistic vision of society as well. Sometime, and especially on drug policy, rub on the way they will be dealing with the issue. The second thing is what I see is at least in the French debate, but that could apply actually to the global debate as far as I've seen it, that reflection and risk-taking only happen in exceptional times, electoral periods. The drug issue is not a cause in itself, but it's an electoral tool or priority. It actually in the French debate, it comes and go through the electoral processes, and between, well, it's business as usual, more or less, unless we have a case as in the north of Paris or issue around the crack use, and then the solution is an electoralist one, is to put a wall to reassure the communities. So this exceptional timing is something to explore, and how the lesson from this exceptional times have been learned or not. And at the global level, the UNGASS engagement in 2016 was an exceptional engagement because it was urged by President calling for global debate. It was not really planned as the way it took place. And the third or second point I wanted to make was on the concept of repression and control, and the need to engage with policemen and law enforcement agent. There's this tendency when we say that the repressive approach doesn't work to also recreate some categorical thinking that control is not needed. Well, I don't think that drug control is not needed, and that the only way of dealing with drugs is to legalize every drug. Actually, I also believe legalization is a way of controlling access and use of drugs in different ways and on different kind of substances. So this tendency to oppose control with legalization or repression, or put repression and control into the same basket also is a bias, a conceptual bias that slow down our policy and research thinking on that. So I don't know if I really answered the question, or that I actually forgot, but that's the point I wanted to make.
Karine, would you like to add something on the Canadian context?
Yeah, maybe for the Canadian context, maybe I can say that the repressive approach is not really important. There's a really a shift in the way that we conceptualize drugs. It's not a perfect consensus, but for example, for the cannabis legalization, it was not that difficult to when it comes to pass the legalization, the perception in the population and in the vast majority also of political stakeholders, for example, it passed in a way. There was some preoccupation about the youth, like Marie said. That was the point that was a lot. The only point that was difficult and that was less consensus is about the use for the youth. For example, in Quebec, the legal age is 21 years old, and elsewhere in Canada, it's 18 or 19. It's the same as for alcohol, for example. So in Quebec, the Ministry of Health, the minister, in fact, is a neurologist who work. They really base their position with, for example, research data about the effect of cannabis on the youth for the biological effect, for example. Le cerveau, I have a blank. So brain, yeah, exactly. So the effect of the brain. So they really on clinical data, and there was really a hard debate between all medical profession, because public health, for example, in the public health associations and doctors from with the public health specialization were really against putting 21 years old, for example, to smoke cannabis in Quebec, because they explained that we will just we think we will protect youth, but in fact they will go to the black market and have dangerous product instead of legal product that is more secure. So that was the kind of debate that we had, and we see that there's, in fact, the preoccupation for youth is not. We see that it's not the preoccupation that were communicated is not happening. So I would say that there's a large consensus in Canada that it was a good decision for the cannabis legalization. There is not really debate that we should go like it was before, for example. So that's and even for the police, I agree that they need to come in the dialogue. And even for example, the police at the federal government, so Royal Canadian Mounted Police, they take a public position about decriminalization, of all drugs also, because they see the limit of a repressive approach. So even when the dialogue, we have community police. So I agree that it don't mean that we don't have to control. In fact, we want to protect the discourse. The public discourse is more about the preoccupation with dangerous drugs, with the black market that is, with the COVID-19, is even more dangerous. So we want to control the illegal market because it's dangerous for the person who chooses to use drugs. So that's the way it is discussed in Canada.
Laurie?
Yeah.
I don't know if you see, but we have a police officer, Fabien Billerand.
Yeah, we have a police officer in the chat saying he particularly shared your points about the need for dialogue between police officers and lawmakers and so on to explain that public policy in France doesn't work. He also asked what was the main argument in Canada to allow this change in the law about cannabis.
Okay. Maybe if I can answer to this second question, one argument is that the fact that the just say no approach doesn't work. And we have like a illegal practice that was with a large part of the population who use cannabis and is considered like doing a criminal activity. So there's an incoherence between the illegal aspect and the important part of the population who use. That's one, and the fact that the repressive aspect just say no don't works. So the choose to regulate and to put more money also in prevention instead of repression. So all the money that we put in repression without having any results, concrete results. So it's a choice of society to put this money to prevent use and also to the matter of security, because the preoccupation to have a legal offer of this product, because for example, for the youth, we want more that they go to the legal offer instead of the black market. So I would say the prevention approach, the fact that just say no is not working, and the incoherence between the repressive approach and the fact that a large part of population in fact use cannabis. I would say that was part of the important argument that was put in light. Yeah.
Laurie? Is it possible to add something very
yes, very briefly, please?
Very briefly. I think that what is also important to say is that in France, there are several tools that have been implemented by OFDT, the French Observatory on Drugs, and in their quantitative polls, they showed that the French population is more and more aware that a prohibitionist approach doesn't work. And that's also important to say that there is a gap on the discourse of the politicians that is still very focused on a repressive approach, and the evolution of the French population who is more and more aware that it doesn't work.
Well, thank you, Marie. Thank you very much to all of our speakers today for this very insightful discussion about drug policy in Francophone countries. So we've reached the end of this panel. Please check the upcoming panels on the website of the conference. Thank you very much.
Thank you for listening to the OC24 podcast. For more talks, have a look at the podcast feed on whichever platform you use. There are loads more to listen to. Video versions of these talks are also available on the Global Initiative Against Transnational Organised Crime YouTube channel. If you would like to share these talks around, we ask that you use the hashtag OC24 and let us know what you think. The 24-hour conference on global organised crime is brought to you by the European Consortium of Political Research Standing Group on Organised Crime, the Centre for Information and Research on Organised Crime, the International Association for the Study of Organised Crime, and the Global Initiative Against Transnational Organised Crime. For more information, head over to oc24.globalinitiative.net. This has been the OC24 podcast from the Global Initiative Against Transnational Organised Crime. Thanks for listening.